I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. And I'm excited today to have with us as our guest, Dean Jargo from Fair Market Health. Dean, good afternoon.
Good afternoon. Thanks for having me on.
Sure. It's great to see you again.
Yeah.
Tell us a little bit about yourself.
I am, like many people who end up in the employer health benefit space, I did not have a design to work in health benefits. I ended up here somewhat happenstance. I'm actually a accounting and finance person by training and spent 30 years doing the finance thing, doing mergers and acquisitions and working in CFO roles and, living all the finance life. And I loved it. But I saw an opportunity coming up now close to 10 years ago to be more involved in the healthcare space. I'm a free market guy. I believe in the power of free markets to solve most, if not all, of our problems. And so I saw that, from my outsider's standpoint at that point, that free market principles were not being applied to the healthcare space. And so I was excited to jump in and see if I could help drive some of that forward.
That's awesome. So let's just cut to the chase. What is wrong with our healthcare system here in the United States today? I know that's a really broad question, right?
I was going to say, I thought we only had 30 or 40 minutes, Larry. I spend the whole time talking about what's wrong. Just starting with a list that I think is relevant is we've got an incentive misalignment problem almost across the board. Hospital systems, large insurance carriers, many benefit advisors are whether they would admit it or not are also financially conflicted, and so nobody really working in positions of power in the current system are really interested in getting patients better. The only people in the system who care about that are the actual doctors and healthcare professionals who are delivering the care. Almost everybody else, and I know I'm painting with a broad brush, there are certainly exceptions, good people working in some organizations that maybe don't behave so ethically. But yeah, I think there's a fundamental misaligned incentive problem.
Sure. Tell us a little bit more about that misalignment.
Well, for one, most people don't understand this, but insurance companies, because of the Affordable Care Act, there's a little provision in the Affordable Care Act that I don't think gets enough attention, and it's called the medical loss ratio. And so the idea when Congress passed that little provision as part of the ACA back in 2010, the idea was, these insurance companies are greedy and we need to force them to take some of the premiums that they've collected and pay it out to members as healthcare claims. And again, on the surface, that seems like a reasonable thing to assert and to require. And so for large employers, large payers, they basically fixed their margin at 15%. So now an insurance company can't make any more than 15% margin. Well, most of these companies are public entities, which means they answer to shareholders. Their fiduciary duty is their shareholders. The fiduciary duty is not to their customers. They exist to increase shareholder value. And so when you're a public company answering to shareholders and you have a fixed profit margin because of what the government mandated, well, how do you make your profits grow? You make the overall pie grow. And so insurance companies actually like it when claims costs go up because then they can justify more premiums. And as that pie grows, their 15% slice becomes a bigger number for them. And so this idea, there's a lot of misconceptions, I think, because there'll be very public fights between hospital systems and insurance companies, right? And what's interesting is most of the time people are on the side of the hospital, right? They say, oh, you got to include this hospital. Or hospital system. So the insurance company is under tremendous pressure to make sure that all of the, big local name brand hospital systems are part of the network. Well, that's a terrible negotiating position to be negotiating from, right? Your members insist that you have this supplier, and what that allows is the supplier then can basically charge whatever they want to charge. And again, because of the misaligned incentive on the insurance side, the insurance company's kind of okay with that, right? Because that makes their pie go up. And so there's two very simple examples of where incentives are not really aligned with two major players. And then benefit advisors, a lot of them do get paid commissions based on the insurance. And so as these many companies are dealing with 10, 15, 20 plus % increases in the total cost of their health care program, if your advisor is being given a raise every time your cost goes up, that's not a good position to be in. And the reality is, most employers have no idea how their benefit advisor is paid. Or if they know this much of the compensation. There's a whole bunch of it that goes undisclosed.
Sure. So, okay. So if I understand you correctly, the misalignment that you're talking about, there's multiple factors. Number one, the insurance carriers can only keep a maximum of 15% of the total revenue they bring in, right? Yep. So it's in their best interest to make sure that the total revenue they bring in is bigger, so that 15% of a bigger number is a bigger number, right?
Yep.
So the revenue is coming, at least in part, from, well, let me back up. So how do they justify increasing the revenue? Because the person that's paying them is the employer, right? For the most part, the employers are paying for most of that increase in revenue. Well, how do they justify charging the employer more? They justify charging the employer more because the hospital, which is probably the single biggest entity, which is causing the insurance company to pay more money, the hospital raises its fees because it's in the hospital's best interest to bring in more money.
Yep.
Now, the insurer, as long as they can get the employer who's footing the bill at the end of the day, as long as they can get the employer to actually pay that bill, it's in the insurance company's best interest to send the employer a larger bill because they get to keep 15% of that larger amount. Yep. So the hospital system charges more, which means the hospital system gets more money, which means the insurance company can charge the employer more, which means the insurance company gets more money, which means ultimately the hospital's making more money, the insurance company's making more money at the expense of the employer, and ultimately at the expense of the employee, right?
That's right. That's absolutely right.
Because of the Consolidated Appropriations Act, which made it really, really clear.
Yep.
What those fiduciary responsibilities are. So can you go into that a little bit more with us, the Consolidated Appropriations Act, and what that clarified and what that does to employers and employees in this whole scam, if you will?
Yeah, you bet. And the CEA, Consolidated Appropriations Act that you're referring to from many years 21. ago, something like that. That was primarily directed at another key problem in the U.S. healthcare system, in that there's no transparency to what anything costs. The way we're all accustomed to paying for healthcare services, you go get the service, and then once you're done with it, then the bills start showing up, with your out-of-pocket obligations plus whatever your employer is chipping into the pot. So obviously, to extend that to any other part of the economy, how effective would we be as consumers at the grocery store or the gas station or the car dealer or whatever it is, if no prices were ever disclosed up front and we only found out the cost of things after we, got the item home? That fundamentally doesn't work, and it also doesn't work in the healthcare space. So the CAA of, I think it was 2021, attempted to get at that. It put a requirement first on hospitals to disclose their prices. Now, the problem with the way it was enacted initially was there was no real penalty. So if you imagine some of the biggest hospital systems around the country that have, by the way, been gobbling up independent practices over the last several years, they, $1,000 fine means absolutely nothing to them. So most of the large hospital systems just elected to pay the fine if anybody ever came knocking. And by the way, nobody ever came knocking, right? I mean, it's not like there's an auditor marching around every hospital making sure that they're complying with this mandate. And so it was again a well-intentioned idea, but it just didn't have consequences attached to it. They've since made some efforts to fix that, so to put real penalties behind hospitals who don't disclose their prices. And the part that is always amazing to me is most states have consumer protection laws that say you can't dupe people. I mean, that's the whole point of consumer protection laws, is you can't dupe people. Well, what is a bigger example of duping somebody than providing a service to them and then sending them a $25,000 bill that they had no idea was coming? So hospitals were required to disclose their prices, and more of them are. We're still not at 100% compliance with that law. And then the other part of it was the payers, meaning the insurance companies, were also to disclose their negotiated rates. And so the whole idea was, let's create more price transparency in the market. And that has had some positive effect, but it hasn't yet kind of reached the tipping point where it really is allowing people to drive better decisions on a day-to-day basis.
Sure. So now the other piece of the Consolidated Appropriations Act has to do with fiduciary duty, right?
That's right.
And so for those of our listeners who may not be familiar with that, and again, Dean, correct me if I'm wrong about this. Fiduciary duty, this whole idea of fiduciary duty came from ERISA, right? From the 1970s. Yep. And it had to do with who was responsible for what when it came to, I think it was life insurance and also retirement benefits, wasn't it?
Yep.
So if an employer was providing life insurance benefits and retirement benefits for the employee, the employer had to spend the money as though it wasn't the employer's money. They were actually spending the employee's money and had a fiduciary duty to put that employee's interests ahead of the company's interests when it came to spending that money for that purpose. Am I right about that?
That's it, exactly.
Okay.
Yep.
So then the debate has been going on for the last 40 years, maybe 50 years, about whether or not that same law applied to healthcare benefits, right? And some people argued, yes, it does apply to healthcare benefits. The employer that's providing these services has a financial fiduciary responsibility to the employee because it's not the employer's money that they're spending, it's the employee's money that they're spending. And other people argued, no, that's not the case, right?
Yep.
And then the Consolidated Appropriations Act finally made it clear which side of the argument the government finally falls on. So tell us a little more about that.
Yeah, so they clearly landed on the side of the employer is the fiduciary, and there's a standard that must be followed if you're a fiduciary, both as a company, and by the way, individuals at the company can also be, personally named fiduciaries. In fact, you don't even need to be technically named. It has more to do with what is your function in terms of managing the health plan. So if you're a CFO and you approve every budget line item, which includes the benefit plan, well, you're a fiduciary of the benefit plan, and you can have multiple individual fiduciaries in addition to the company. But the standard is you have to operate with prudence. What a reasonable person would consider prudent. And again, the question that has to be asked is, can you operate as a prudent fiduciary when you've designed a health plan that has no transparency into what anything costs? That does, to me, I'm not an ERISA attorney, but that certainly doesn't sound like a prudent behavior on behalf of the employer or the people, the individuals who are helping to design and run the company benefit plan.
Right. So if I understand you correctly, the Consolidated Appropriations Act made it clear that when the employer spends money for a benefit plan, the employer isn't spending the employer's money. The employer is spending the employee's money, and as a result has a very specific responsibility to that employee to spend that money the way the employee would want it spent.
That's it.
Okay.
That's it, exactly.
And to your point, in the absence of price transparency, then how is the employer supposed to be able to spend that money wisely on behalf of the employee? It's not the employer spending their own money. It's the employer taking the money from the employee and then spending it on something else on the employee's behalf. And you could argue, if they're not doing it well, they are, in essence, embezzling isn't quite the right word, from a technical standpoint, but you get the idea that, okay, well, you're mismanaging my money.
Yep. Well, and play it out one step further, because we see this all the time in our business, is employees, because they don't have any transparency into what do things cost, they can't make trade-off decisions. They can't say, well, I'm willing to drive an extra mile to save $3,000. We see this all the time. People end up in a hospital to get a routine MRI. They tweak their knee and they end up needing an MRI. And we see this all the time. Hospitals will charge $3,000 or more for that MRI, where there's an independent imaging facility virtually across the street that will do it for $500 or $600. And again, patients would make better choices if they had the data and information they need to make that better choice.
Particularly if they saw how it impacted their own bottom line.
Exactly. Yeah. Exactly.
Yeah. I mean, I'm a living example of that very thing that you're talking about. I had an MRI of my shoulder. This is when I was an employee of the hospital.
Yep.
And, my doctor, I figured I'm an insider, so they're going to take good care of me, right?
Yep.
I found out not too long after that assumption wasn't well founded. So I get the MRI at the hospital because I'm an employee of the hospital. I figured, that's got to be a good deal, right? It was $5,000 and my deductible on that was $3,500. So I was really grateful that the insurance company paid $1,500 on that, right? I was like, this is a good deal.
Yeah.
And then a few weeks later, I had a patient come in who needed an MRI of some other part of the body. And I said, hey, you need an MRI. He goes, oh, doc, I really don't like MRIs. I said, yeah, I can sympathize. I had one done recently of my shoulder. He goes, yeah, I had an MRI done on my shoulder. They're really expensive. I said, yeah, you're no kidding. And he said, yeah, it was $500. I said, did you say $5,500? And he said, no, it was $500. And I was like, are you sure it's an MRI and not a CT scan? He goes, no, it was an MRI. Go ahead, look at my medical record. So that's what I did. I looked in the medical record, right? And what did I see? The MRI was done on the same model machine as my MRI, same part of the body. Okay, I had a shoulder MRI. He had a shoulder MRI. It was done on the same model machine. It was read by the same radiologist.
Oh my gosh. Yeah.
His was done across the street at an independent freestanding imaging center. Mine was done in the hospital. Yeah. Mine cost $5,000. His cost $499.
Yeah.
And I was like, it's the same machine. It's the same radiologist. Why did mine cost literally 10 times as much?
Well, and the other thing to add to it is typically the independent facilities are more convenient, right? Because, you go into a large hospital system, you got to walk down 12 hallways to get to the area, dealing with the specialty you're needing. And, independent facilities, you walk to the front door and boom, you're immediately taken care of.
Sure. So bottom line, let's summarize all of that. So hospitals make more money by charging more money, right?
Sure. Just like every business.
Exactly. Yeah. The insurance company makes more money by not fighting too much with the hospital over how much the hospital is charging. Sure, there's some public fights between hospitals and insurance companies, but they're really arguing over the crumbs, not over the pie, right? And so they make it public so they put up a good show, right?
That's exactly right. It's a show.
That may sound a little cynical, but I don't think I'm too far off on that, right?
You're not.
But ultimately, so the hospital makes more money. The insurance company makes more money. Well, where does that money come from? It comes from the employer. But again, whose money is the employer spending? The employee's money. So who is paying this bill? Is it the insurance company? Like when I go, my deductible has been met, so I can do whatever I want because my insurance company is going to pay for it. Is it really the insurance company that's paying for that?
No.
It's the employee that's paying for it. They may not pay today, they'll pay next year in their premiums, right?
Well, and some people will get a little confused because, there's this thing called being fully insured and this
Right.
thing called being self-insured as an employer for the health benefit plan. And a lot of people who are fully insured, meaning they don't think they take any risk, right? All the risk exists with the insurance company. But, I always ask, well, what happens when your claims increase because somebody had, a bad accident or whatever happened during the year? Do you think the insurance company is not going to bring you a big premium increase? Yeah, absolutely they are. So the problem with fully insured is you get all the downside with none of the upside, meaning if your claims are actually lower than the premiums you paid in, you don't get to keep any of that money. You've already sent it off to the insurance company. And so yeah, there's this whole world of fully insured versus self-insured that I think a lot of employers need to wake up to as well.
Sure. So, for the last, what's it been, 20 minutes or so, we've been talking all kinds of doom and gloom about all the things that are wrong with the healthcare system, right?
Yep.
Now, I would imagine a lot of our listeners are thinking, well, man, that really sucks. And I guess that's the way it's got to be. It's going to suck until we have a single payer system or until we have universal health care that, that the government pays for, right? So we have a system like Canada, where 1 out of every 20 people dies at the hands of a physician on purpose, right?
Right.
The fifth leading cause of death is physician assisted suicide, right? Because that's cheaper than paying for the cancer treatment. That's cheaper than paying for the MRI. And if you don't, for those of you that are listening that don't believe me, go to the Canadian Federal Healthcare website and take a look at their own statistics. You'll see that it's about 5% of the deaths in Canada last year were due to physician-assisted suicide. One out of every 20 deaths. That's what happens when you have universal health care. When the government is paying the bill, the government's going to decide, okay, who's going to get what, right? I mean, ultimately, that's what happens. In any case, there are going to be a lot of people who are listening to this who are going to say, well, that's really the only way to fix it. Is it, Dean, the only way to fix this problem?
No, not in my opinion. As I said at the beginning, I'm a free market guy, so I'll admit that defect up front, but I really do believe that free markets deliver the best quality, the lowest price, and the most convenience. And you can look across almost any industry and prove that out. And some people will even say, no, we already have a free market system in America for U.S. healthcare. And I totally disagree with that. We don't have anything close to a free market system in America. In fact, what people forget is half of the people in the U.S. are covered by a government program. It's Medicare, it's Medicaid, it's TRICARE, it's the VA system. That accounts for half of the spending in the U.S. So when you say, we don't want government-run healthcare, I was like, we already have government-run healthcare. Right. And by the way, go ask most people what they think of those systems, either on the patient side or the doctor side. Somebody is usually getting the short end of the stick in those systems.
Sure.
And unfortunately, I think for Medicare and Medicaid, it's the doctor.
Sure.
Most patients are reasonably satisfied with Medicare, but we would have I believe, a massive physician shortage if we went to universal health care. Everything was negotiated and paid by the government. Reimbursement rates would fall to a level where, supply and demand does what it does.
Sure.
And I think supply would be severely restricted if we went to a model like that. So free market is the way for me to accomplish a better U.S. healthcare system, and it involves all the things that we're talking about:
Sure.
Fiduciary responsibility, price transparency, removing some of the unnecessary middlemen that are involved in extracting as much value as they possibly can, while patients aren't necessarily being cared for any better by any of so the middlemen don't care about making people healthy. Again, it's only the physicians and healthcare professionals who care about that.
Right. Yeah. I mean, I can give you a few concrete examples. So I had a patient recently who needed an audiogram. He just he was finally able to get a hold. This is in the VA system, okay?
Yep.
He was
Yep.
finally able to get a hold of the VA. It took him 3 weeks to actually get a hold of somebody because they kept playing phone tag with each other. When he finally got a hold of the VA, and it's the end of June now. His appointment is at the end of September.
Oh my gosh.
Okay.
Yeah.
I had a patient that came to see me from Canada, and she's interested in surgery. I said, okay, well, because of your age and because of other things, you need what's called a stress echocardiogram. Now, this is the
Yep.
universal healthcare system, right? She said, oh, that means I have to see a cardiologist? I said, yeah. She said, well, it'll probably be a year before I can get that test done. You know, I
Oh
mean,
my gosh.
yeah,
Yeah.
exactly. So the average wait time to see a plastic surgeon, let's say you got a cleft palate or something like that, and you need to get that fixed, average wait time is over a year to get in to see that plastic surgeon. And if you got a cleft palate, you need, by the time you reach a year old, you have to have had at least 3 different operations in order to fix that cleft palate appropriately.
Yeah.
And
Right.
it's a year before you actually even see the surgeon to get the appointment set up for your 3-month operation.
Yeah.
It's
No,
crazy.
thank you. Yeah.
Yeah, exactly. So, okay. So again, we've been talking gloom and doom, and we've spoken conceptually about the fact that free market medicine is a better option. Tell us more about that. What are you doing in free market medicine? What does that look like? How does that
Yeah.
solution look?
Yeah. So for our business specifically, which falls into what's called the direct contracting space, and direct contracting really is a pretty simple idea because, as we've already established, employers provide healthcare through their company health plan to half of Americans. So 165 in round numbers, 65 million Americans get their healthcare provided to them through their employer's health plan. And so the employers are important buyers in this market, and they're obviously working on behalf of their employees and their dependents. So that's one side of the marketplace. And the only other side of the marketplace that really matters is the people providing the care, the doctors, nurses, physical therapists, all the people who are, hands-on treating patients, right? But we've got this big organization sitting in the middle, which is called an insurance company, who gets to play, judge and jury for everything. The doctor sees a patient, recommends a course of treatment. Well, got to run that through the insurance company and play mother may I, to let the insurance company decide, is it covered? Is it even medically necessary? Even though, again, they've never examined the patient for 1 second. And again, that pushes a bunch of burden back to doctors. So all of that to say, for so much of healthcare, we do not need an insurance company at all, because employers are very happy to pay fair and reasonable prices for healthcare services delivered to their employees and their dependents. And doctors, on the other side, are very happy to be paid fair and reasonable prices, as long as it's being paid without a bunch of headache, nuisance, denials, prior auths, all the things that insurance burdens on to doctors and other healthcare professionals. And so our solution is, look, you don't need an insurance company to connect the two parties that matter, the doctors and the patients through their employer. And so we've built a technology. I describe it to a lot of people as Amazon, but for healthcare services. And what is Amazon? It's a connecting website that brings a bunch of suppliers and a bunch of buyers together and makes it easy for them to shop and be paid and all of that. And we do effectively the exact same thing. And in doing that, we typically reduce healthcare spend by about 35%.
That's awesome. So let's look through a concrete example, if you can.
Yeah.
Let's take the example of somebody who needs a knee replacement.
Perfect.
Tell us about the differences.
Yeah. So one way to get your knee replacement is to pull your insurance card out of your wallet and look up on the net, the website or whatever that says, okay, here's the orthopedic surgeon I'm going to go to because, my neighbor Joe said this, that's who he went to. Okay, great. You get the insurance card out, you go to the first appointment, the surgeon confirms, yep, you're a candidate for a knee replacement. Let's schedule that for, 2 weeks from now. Great. It's going to work exactly as we described before. You're going to start getting bills about, 4 days after your surgery. You'll get a bill from the anesthesiologist. You'll get a bill from the facility where your service was performed. You'll get a bill from the surgeon who actually performed the knee replacement. And all those bills start showing up. And of course, you as a consumer have no idea what's what and what's fair and reasonable. And of course, your insurance company is involved in, helping decide, well, what should this doctor actually be paid? But the reality is, as a patient, you're going to have out-of-pocket responsibility, right? Because every plan has deductibles, co-pays, co-insurance designs. And so the member is going to have to pay, for a knee replacement, it could max out their max out-of-pocket, right? And for some people, that's $5,000, $10,000, $15,000 that many people don't have as disposable assets, right? It's just, they don't even have that in their bank account to begin with, and they're burdened with this, very expensive out-of-pocket cost. That's how it's traditionally done. The way it can be done, the better way, is an employer can offer to their employees, and they say, look, instead of pulling your insurance card out and going down that route, you can just go visit fairmarkethealth.com, find the service that you want, find the surgeon that you want, put that in your shopping cart, check out. And if you do it that way, buying direct from the surgeon effectively, we, the employer, your employer, will pay 100% of the cost. You have no patient responsibility. Now, again, we're giving patients choice, which I like. They can go down the insurance route, or they can go down the direct to provider route. And based on that decision is going to determine whether they write a check and how big of a check.
Sure. Now, let's say I'm the employer. I'm going to play devil's advocate now, right?
Perfect.
I'm the employer. Why the heck would I want to pay the whole bill on that total knee replacement going through Fair Market Health?
Great question. So let's pretend, and this is not a real hypothetical, because we see this every day. We were talking about high-priced MRIs in the hospital setting. Well, joint replacements work exactly the same way, and so it is not unheard of to get a joint replacement at a large hospital system and get a $50,000+ bill, right? And so if you have a $10,000 deductible, actually, let's say $5,000. If you have a $5,000 deductible, you, the employee, are going to pay $5,000. Let's ignore co-insurance for a second, because that makes the math a lot more complicated. But you at a minimum have a $5,000 deductible. That means your employer is paying the other $45,000, right? So somebody's writing that check, and it's your employer, if they're self-insured, which most employers are.
And whose money is the employer spending in that scenario?
Well, the argument, of course, is that, hey, if we didn't have to spend all this money on healthcare services, we could put more money into the employee's paycheck. So absolutely, in that sense, it's the employee's money, right? It's the raise they're not getting, and year after year.
Right.
So now the employer is out $45,000. The employee's out $5,000. Okay, now let's move. That was the insurance. Now let's move over to the direct method. If you buy it direct, typically you're going to pay some number around $25,000 or below. But let's just say it's $25,000. Okay, so now the employee pays zero, right? No $5,000 payment due. The employer pays the whole $25,000. Which one was better for the employee? Clearly, it was better to buy direct because they got their $5,000 waived. But look at the employer situation. $45,000 over here with insurance and $25,000. The employer saved $20,000.
Right. And so if I hear you correctly, I already know the answer to this, but I'd like everybody else to hear the answer to this. That $25,000, or really, yeah, $25,000. That $25,000 where does that end up? Does it end up in the hospital? Does it end up well, let's set aside the hospital. Whose pocket does that go into?
It primarily ends up in the hospital, right? This takes us all the way back to the beginning,
Yes.
where hospitals, they're in a somewhat enviable position if you just look at it from a business standpoint, right? People would riot if the big hospital system in town wasn't included, as part of their health benefit. And so hospitals know that, and using that leverage, they jack their prices way up. And because nobody sees the price up front, you're not the wiser until after the fact.
Right. Okay. So this sounds like a great option. Obviously, I know it's a great option.
Actually, can I add one other thing that you just made me realize?
Please.
The important thing here is all that extra money is not going to the physician. People have this idea that, doctors are the ones who are making healthcare so expensive. That is 100% false. It's the large entities, many of them even nonprofit, that are raking in all those extra dollars. The physician is going to be paid basically the same whether they're working in the hospital system to deliver the surgery or whether they're working at an independent center. The physician's pay doesn't move materially between those two.
Right, exactly. And typically for a surgeon, it ends up being about 10% of the total bill.
That's right.
So that's if you're working through an insurance company. But the benefit for the surgeon is that if you're working through fair market health, even though the total bill is smaller, because you've cut out the insurance company and you've cut out the hospital and you're doing a surgery at a surgery center, it's going to be greater than 10%, even though it's 10, even though it's greater than 10% of a smaller number. The net effect is still that the surgeon gets paid more, the anesthesiologist gets paid more, the surgery center gets paid more, and the employee and the employer paid less. Did I get that right?
That's exactly right.
Okay.
Yep.
So this all sounds great, but I mean, Dean, it's got to be really horribly complicated to get plugged in with something like this, right? I mean, this sounds way too good to be true. If, I'm a surgeon, and obviously I already know the answer to this because I signed up with Fair Market Health, but let's pretend that I hadn't, right? I'm Joe Schmo surgeon. I'm thinking about doing this, or I'm Joe Schmo employer, ABC, widget maker, and I'm thinking about doing this for my employees. I mean, this has got to be really complicated, right?
Yeah, no, not at all. In fact, we've worked hard to make sure it's not complicated, either for the healthcare professional or for the employer or patients. And on the provider side, on the doctor side, what I typically say is you can be up and running on Fair Market Health in under 30 minutes. There's really 3 steps. There's an onboarding form that you fill out that, here's our practice name, here's our address, a very basic form. That's step number 1. Step number 2 is tell us what your cash prices are for whatever services you want to offer. So services and prices. And, a lot of folks have that in a spreadsheet and they just email it over to us, and we take those services and those prices and upload them onto our marketplace. And then the third step, and this is the one physicians ultimately love the most, is we connect via ACH to the physician's bank account. Why do we do that? Because as soon as that service is delivered, our system will schedule the payment. So typically physicians are being paid 4 to 5 days after they deliver the service. And they don't have to do any coding. They don't have to do any billing. They didn't typically have to mess with any prior auth, which meant they didn't need to deal with any denials that came from the prior auth. So if you ask the physician to list out all the things they hate about insurance, we've worked hard to get rid of all of them. We just say, look, we don't need any of that. Give the employer and their employees a fair price, and in exchange, the employers are very happy to pay very quickly and without all that other hoop jumping.
Sure. So you made it sound really, really easy, which I know it is from personal experience, right? But it's really easy for the doctor, but it's got to be super complicated for the employer, right?
Yep. Great question. So for the employer to get set up with Fair Market Health, it's also a less than 30-minute process. And in some sense, it looks similar. We need an eligibility file so we know which of your employees and dependents are actually on your health plan. And that's an automated process. It takes a very short amount of time to do. We do have an agreement that the employer needs to sign to participate on the marketplace. It actually has more obligations on us than it probably does the employer in terms of the contract. And then the last thing is we need to connect to their bank account, because again, the way we deliver on our promise to physicians is we get paid at the point of purchase, which is a very radical concept in healthcare, right? Because we're so used to service delivered and then the money is figured out after the fact. And we think that's ridiculous, because if you're direct contracting, you know your cash prices, and we can communicate those to members when they click the buy button. That's the amount of money we need to pull from the employer's bank account, so it's in position to pay to the performing physician, ideally within a few days.
Sure. So basically what you're saying is that you're the guy that has the menu. It's like going into a restaurant. So the employer goes in and says, okay, I need 3 pizzas. I need, 2 bottles of root beer, and I need, 5 orders of fries.
Yep.
And then the doctor is the one that provides those. The doctor says, okay, these are the prices you're going to put on the menu. You show the menu to the employer, and the employer says, oh yeah, those prices look good. Boom, done.
Yep. Yeah, I mean, it's a good analogy. Like, I don't use any of these services, but my kids do, Grubhub and Uber Eats and all of those things. Those platforms, for lack of a better word, those marketplaces, they list all the menus from all the, restaurants in town.
Sure.
And they bring to that marketplace all the people who want the convenience and transparency of, oh, I can shop at all of these restaurants.
Sure.
By going to one spot. And, oh, by the way, the convenience of having it delivered to me is, cherry on top.
Sure. So then, to extend your analogy, fair market health is like the Grubhub of healthcare, whereas the conventional model is like going to a restaurant where the menu has no prices.
That's it.
You eat the food and then you find out, oh, that was $1,000 Coke. I'm not sure I want $1,000 Coke. Well, too bad. You already drank it.
Well, and one thing I'll add too quickly, which is important for your viewers to realize, your physician viewers will realize this, but I think a lot of employers just don't really think about the fact that, insurance companies and insurance networks brag about how many doctors participate in their network, right? They'll throw out statistics like 97 or 98% of doctors participate in our network. Well, what's the reality of that? There's really no screen on quality, none, right? And people, if you ask people how do you prioritize quality in terms of healthcare service delivery, they put it at the top of the list, right? It even goes above price for the most part. They want high quality healthcare providers, and insurance networks don't do anything to help the consumer from that standpoint. So it's a very important part of the equation that needs to be factored in.
Right. Okay. So as we wind down, I have three really important questions for you. Okay.
Great.
Number one, for those physicians out there who are thinking about going into direct care, what is your single biggest piece of advice for them based on your experience, based on everything you've seen?
Don't wait. The market is moving right now. Employers, they've been crushed by the U.S. healthcare system, which is very insurance centric, and they are absolutely waking up to the need that they need to do something different, and which means operating a little bit outside the insurance carrier networks. And so employers are moving en masse into this market, if you will. But physicians, I think, are still a little sleepy, or, just don't know yet that this is even an option. And so I would just say, jump in with both feet, because again, by the way, there's no cost to participate either on the physician side. So, you have, again, virtually no downside with all this potential upside to make your practice more profitable, improve your cash flow. I mean, increase your quality of life because you're not spending all that extra time on prior auths and denials. And so much of the practice can be improved by just getting into the direct contracting world. And it doesn't have to be through Fair Market Health. You could do it with others, but
Sure.
Of course, I'd love to have them on Fair Market Health.
Of course. Okay. Second of the three questions. We have an employer that's listening that maybe is fully insured, or maybe they're self-insured, right? And they're thinking about getting into direct contracting. What's your single biggest piece of advice for them?
Well, in order to get in order for direct contracting to make sense, you have to be self-insured, or what I say more accurately is partially self-insured, right? You still have stop loss insurance that kicks in at some point to protect the company from catastrophic claims. So my advice is, if you're fully insured, look very hard at seeing if you can operate as a self-funded health plan. That's number one. And then if you are a self-funded health plan, don't kid yourself that if you've got Blue Cross or United or Aetna or Cigna or any of the other big names, that you are being protected by that logo or their network. They are 100% looking out for themselves. And again, there are other and different options, direct contracting being one of them.
Sure. And, for those who are listening, one of the things I tell a lot of my patients is that, just because you have that logo on your card doesn't mean that they're the ones that are paying the bill. It's just like having a MasterCard logo or a Visa logo, right? I mean, when you swipe the card at the gas station, is it really MasterCard that's paying for your gas? Right. No, you're paying for it. The MasterCard just happens to be the vehicle by which that payment occurs. And of course, they charge a hefty fee. Well, these big insurance companies, their hefty fee is way more hefty than the credit card. I mean, talk about the most expensive credit card you could possibly have. That's it right there.
You got it.
Right? Okay, third question. And actually, before I get to the third question, I'd like to invite you. I know we talked about this earlier, but I want to invite you to the Nebraska Chapter 2026 Annual Free Market Medical Association Conference. It's on the 21st of August. I'm also inviting anybody that is listening or watching this. It is no charge, and it's going to be huge. Our last one had over 100 attendees. We're expecting about 300 attendees this time from all over the country. It'll be the single largest free market medicine conference in 2026 anywhere here in the United States. So come on out. Dean, we'd love to have you again.
Well, count me in. I came to the one last year and it was great, and I know they're only getting better. So count me in.
Well, we're excited to have you. Third and final question. How do people find you?
Probably the easiest way is LinkedIn. I'm on LinkedIn, and so you can just direct message me there. Or if you want to send me an email, it's just dean@fairmarkethealth.com.
Awesome. Any other last words you want to share before we tie things up?
Nope. Just I appreciate you and appreciate the time to talk through a very important issue.
Thank you, Dean. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.